Essential anesthesia questions for general surgery residents. Welcome to the Everything Surgery podcast, where we'll be discussing fundamental anesthesia questions every general surgery resident should know. Today, we discuss key topics, from preoperative assessment to critical care, in a question and answer format. Pause video when you hear the word answer to attempt answer. Let's get started. Preoperative assessment question. What are the ASA physical status classifications? Answer. The ASA classifications range from 1 to 5. 1. Healthy patient. 2. Mild systemic disease. 3. Severe systemic disease. 4. Severe disease that is a constant threat to life. 5. Moribund patient not expected to survive without the operation. Question. How does the MET system assess functional capacity? Answer. The MET, or metabolic equivalent, system evaluates exercise tolerance. Less than 4 METs indicates higher perioperative risk. Question. When should a patient undergo cardiac clearance? Answer. Cardiac clearance is indicated for active cardiac conditions like acute coronary syndrome, decompensated heart failure, or severe valvular disease. Question. What's the proper NPO timing before elective surgery? Answer. The general guidelines are 2 hours for clear liquids, 6 hours for a light meal, and 8 hours for fatty foods. Question. What's the best way to assess a difficult airway? Answer. Assessment tools include the Malampati score, measuring theromental distance, evaluating neck mobility, and mouth opening. Question. Do all patients require preoperative labs? Answer. Not all. ASA 1-2 patients often don't need labs unless there are specific indications, such as a CBC for anticipated major blood loss. Question. How should we manage patients on anticoagulants? Answer. For warfarin, stop 5 days before surgery to achieve INR 1.5, with bridging if high risk for thromboembolism. DOACs are usually held 1 to 2 days, depending on renal function. Question. Should beta blockers be continued perioperatively? Answer. If the patient is already on beta blockers, continue them, but avoid starting them acutely before surgery. Question. How do you assess pulmonary risk? Answer. Consider pre-existing conditions such as COPD, smoking history, obstructive sleep apnea, and FeV1 below 1L. Question. How do we premedicate for aspiration risk? Answer. Use a PPI or H2 blocker, metoclopramide, and sodium citrate. Intraoperative management question. What are the main induction agents and their profiles? Answer. Propofol can cause hypotension, etomidate, hemodynamically stable, and ketamine, often used in hypotensive patients. Question. Can you describe rapid sequence induction? Answer. It involves pre-oxygenation, applying cricoid pressure, administering induction and paralytic drugs, with no bag mask ventilation in between. Question. What is the difference between MAC and general anesthesia? Answer. MAC is monitored anesthesia care involving sedation and local anesthetic. General anesthesia causes unconsciousness and airway control. Question. Which paralytic agents are commonly used? Answer. Succinylcholine. Rapid onset, short duration, and rocuronium. Longer acting, reversible with sugammadex. Question. What does maintenance of anesthesia involve? Answer. Typically volatile agents like sevoflurane, combined with opioids and neuromuscular blockers. Question. What's TIVA? Answer. Total intravenous anesthesia, usually using propofol and remifentanil. Question. How is the depth of anesthesia monitored? Answer. With a bispectral index monitor, aiming for a score of 40 to 60. Question. When is controlled versus spontaneous ventilation indicated? Answer. Controlled ventilation is used for procedures like laparoscopy. Spontaneous is suitable for monitored anesthesia care. Question. What is PEEP? Answer. Positive end expiratory pressure, which prevents atelectasis. Question. What's the importance of end tidal CO2? Answer. Normal range is 35-45 mmHg. Elevated end tidal CO2 suggests hypoventilation. Low end tidal CO2 suggests hyperventilation or pulmonary embolism. Fluids and hemodynamics question. What is goal-directed fluid therapy? Answer. This involves optimizing stroke volume, often using tools like esophageal Doppler. Question. What's the difference between crystalloids and colloids? Answer. Crystalloids are inexpensive but can leak into tissues. Colloids are costlier but stay intravascular. Question. Can you explain third spacing? Answer. It's a fluid shift into the interstitial space, such as bowel wall edema. Question. How is intraoperative hypotension treated? Answer. Start with fluids, then consider vasopressors like phenylephrine or ephedrine. Question. How do you estimate blood loss? Answer. Use estimated blood volume, EBV, and changes in hematocrit. Question. When should you transfuse blood? Answer. Typically for hemoglobin below 7, or below 8 in coronary artery disease. Question. What is TRALI? Answer. Transfusion-related acute lung injury, presenting as non-cardiogenic pulmonary edema. Question. What are TEG and ROTM? Answer. Viscoelastic tests that evaluate coagulopathy. Question. What is the massive transfusion protocol? Answer. Use a 1:1 ratio of RBCs, fresh frozen plasma, and platelets. Question. What is cell salvage? Answer. It's the intraoperative collection and reinfusion of a patient's own red blood cells. Regional anesthesia. Question. What is a spinal anesthetic? Answer. An injection of local anesthetic into the intrathecal space for rapid onset. Question. How does an epidural differ? Answer. A catheter is placed in the epidural space for continuous infusion. Question. What is a TAP block? Answer. A transversus abdominis plane block provides postoperative analgesia. Question. What are the signs and treatment of local anesthetic toxicity? Answer. Early signs are CNS symptoms, like seizures, followed by cardiac arrhythmias. Treat with lipid emulsion, intralipid. Question. What's the risk with epidural hematoma? Answer. It's rare, 1 in 150,000, but presents with paralysis and requires urgent MRI and decompression. Emergencies. Question. What is malignant hyperthermia? Answer. It's a hypermetabolic state with increased end-tidal CO2 and muscle rigidity, triggered by certain anesthetics. Treat with dantrolene and cooling. Question. How is intraoperative anaphylaxis managed? Answer. Administer epinephrine, fluids, and steroids. Question. How do you prevent and treat postoperative nausea and vomiting? Answer. Prophylaxis involves dexamethasone and ondansetron. Question. What is laryngospasm? Answer. Treat with positive pressure ventilation and, if needed, propofol or succinylcholine. Question. How do you manage aspiration? Answer. Immediate suctioning, bronchoscopy, and sometimes steroids, though their use is controversial. Postoperative care. Question. What are the PACU discharge criteria? Answer. The Aldrate score, dischargeable at 9 or above, based on activity, respiration, circulation, consciousness, and oxygen saturation. Question. What causes delayed emergence from anesthesia? Answer. Check for residual opioids. Reverse with naloxone. Neuromuscular blockers. Use Sugamidex. Or metabolic issues. Glucose ABG. Question. How should postoperative delirium be managed? Answer. Avoid benzodiazepines. Control pain, and reorient the patient. Question. How is epidural analgesia managed postoperatively? Answer. With a local anesthetic and opioid infusion. Question. How is patient-controlled analgesia, PCA, typically dosed? Answer. Morphine 1 mg per dose with a lockout interval of 6 to 10 minutes. Critical care. Question. What are the criteria for ARDS? Answer. PaO2/FiO2 ratio below 300, bilateral infiltrates, and a non-cardiac cause. Question. How should ventilator settings be adjusted for ARDS? Answer. Use low tidal volume, 6 ml/kg, and high PEEP. Question. What's the initial management of septic shock? Answer. Begin with fluids, then vasopressors like norepinephrine, plus antibiotics. Question. Who should receive stress ulcer prophylaxis? Answer. Ventilated or hypotensive patients should get a PPI or H2 blocker. Question. How is venous thromboembolism prophylaxis achieved? Answer. LMWH and sequential compression devices. Pharmacology. Question. What reverses opioids, benzodiazepines, and neuromuscular blockers? Answer. Naloxone, 0.04 mg IV for opioids. Flumazenol, 0.2 mg IV for benzodiazepines. Sugamidex for rocuronium. Neostigmine for others. Question. What's the half-life of heparin? Answer. About 1.5 hours. It is reversed with protamine. Question. How do fentanyl and morphine differ? Answer. Fentanyl acts quickly and has a short duration. Morphine is slower and longer acting. Special scenarios. Question. How is anesthesia managed for a pregnant patient? Answer. By displacing the uterus leftward and avoiding hypotension. Question. What is the protocol for malignant hyperthermia susceptible patients? Answer. Avoid triggering drugs. Use TIVA, and ensure dantrolene is available. Question. How is a patient with pheochromocytoma prepared for surgery? Answer. Start with alpha blockers, phenoxybenzamine, then beta blockers. Question. What is thyroid storm, and how is it managed? Answer. Treat with beta blockers, propylthiouracil, PTU, and steroids. Question. How is carcinoid crisis managed? Answer. Administer octreotide and avoid histamine-releasing drugs. Miscellaneous question. What is the ASA difficult airway algorithm? Answer. Call for help. Attempt mask ventilation, intubation, and if unsuccessful, proceed to a surgical airway. Question. What is the Miller versus Mack blade? Answer. Miller is straight, for pediatrics. Mack is curved, for adults. Question. What is a DLT tube? Answer. A double lumen tube, used for thoracic surgery. Question. What is one lung ventilation? Answer. Isolating and collapsing one lung, often for thoracoscopic procedures. Question. What is the fire triad in the OR, and how can it be prevented? Answer. The triad is oxygen, heat, and fuel. Avoid using more than 30% FiO2 with electrocautery to minimize risk. Thank you for joining us in this comprehensive review. For more in-depth discussions, subscribe and stay tuned for our next episode.